Hi, my name is Dr. Tania Kaprealian, and I'm Assistant Professor in UCLA Radiation Oncology, specializing in CNS tumors, including brain and spine tumors. We do take a multidisciplinary approach in the treatment of our patients with brain tumors, with neurosurgery and neuro-oncology on board with us, as well as a team. Today I'll be talking to you about radiation therapy for brain tumors. I'll briefly go over different brain tumors and discuss the various different treatment modalities we have from the radiation perspective. You can ask questions on Twitter using hashtag UCLAMDChat. So what is a brain tumor? There are primary brain tumors, meaning that they originated in the brain, and these consist of both benign and malignant tumors. They can be meningiomas, gliomas, which is a broad category that includes astrocytoma, oligoastrocytoma, oligodendroglioma, and glioblastoma. There are also pituitary adenomas, acoustic schwannomas, and CNS lymphoma, just to name a few. Then there are secondary brain tumors, and these are known as metastases. That means they spread from a different source in the body to the brain. For example, a breast cancer that has spread to the brain, or a lung cancer. This is looking at the brain anatomy and the various different lobes. You have the frontal lobe, parietal lobe, temporal lobe, occipital lobe, and then the cerebellum and brainstem. Now, the symptoms patients can develop from tumors depend on which area of the brain the tumor originated. And you can see here, right behind the frontal lobe, you have the motor strip, and in front of the parietal lobe is the sensory strip. So if you have a tumor in either one of those, you might have motor symptoms, weakness, or sensory symptoms. Then you can also have speech difficulties if a tumor originates in the speech area. So Broca's area is in the dominant frontal lobe. This is the area that controls motor, but it's also an area that controls expression of speech. So if a patient has a tumor in this area, they will have an expressive aphasia where they have difficulty communicating what they want to say. And that's right here in green. Then there's Wernicke's area, and that's in the dominant temporal lobe. And this is the area where sensory originates from, but it's also an area where a patient can develop receptive aphasia or a difficult time understanding what someone else is saying to them, although they can express what they want to say. And that's this area that you see in blue. Now here is inner brain anatomy. This is if you picture a brain sliced right down the middle and then looking from one side to the other. This pink structure here is the corpus callosum that connects one side of the brain to the other. And inside the brain you can see that there are various other structures in addition to the various lobes that I showed earlier. This is a homunculus, and this is a graphical representation of how each part of the brain controls a different part of the body. So in this image here on the left, you can see the brain as it's sliced from front to back. The image on the right shows you how each portion of the brain controls a different part of the body. So for example, the foot, the hip, the trunk, you can see here. You can see that in this representation, that would be in this general region right here where the arrow is. Now, if a patient has a tumor in that area, they can have either a motory or sensory loss affecting that specific part of the body. What is a glioma? As I mentioned earlier, it consists of astrocytomas, oligoastrocytomas, oligodendrogliomas, and glioblastoma. Here you can see a neuronal cell, and that's the yellow cell, and this is the nucleus of that cell. Around it are the glial cells. So this blue is an oligodendrocyte, and the red is an astrocyte. It's the replication of these cells out of control that causes these gliomas. And here on the right, you can see a glial cell, just in a different representation. How does cancer develop? So it develops from a DNA mutation, and those can be various things. On this left-sided graph, you can see that in the first one, you have a normal DNA. And then the second, third, and fourth image of the DNA shows various different mutations that can develop. So in cancer, basically what happens is you lose normal growth control. So normally you have cell division, and then when a cell develops a mutation, it dies on its own. It commits suicide. However, in cancer, a first mutation leads to a second, a third, a fourth mutation, and that's when you have uncontrolled growth, and this is what leads to development of cancer. Here's a pathology of a glioblastoma. This is what it looks like under the microscope. This is a grade 4 tumor on the right, and on the left is normal brain cells. And you can see here with the normal brain cells, you have the neuronal cells. As I showed earlier in the cartoon format, it was the yellow cell. And here you have the glial cells which surround it. And so you can see here on the right with the glioblastoma, it's not organized appearing at all. On the left, you can see how it has this organized appearance. On the right, you have multiple replications, so you see all these black dots. And this is what we look at under the microscope to make the diagnosis. Here is looking at that glioblastoma on a radiographic image, so an MRI typically. And you can see this first image is looking at the brain sliced from top to bottom. The second image is looking at the brain sliced from front to back. And the third image, the sagittal view, is looking at the brain sliced from one side to the other, from left to right, for example. And this is a very typical image of what a glioblastoma would look like. It's black in the center of it because it has a pocket of dead cancer cells there, but all around it, it has this bright ring enhancement, and it's just picking up contrast. So this is a very typical image of a glioblastoma. What are some common presenting symptoms? Well, they vary again based on the location of the tumor, but they could be headache, seizure, motor weakness, sensory loss, perhaps numbness or tingling, speech difficulties such as aphasia, nausea, vomiting, or unsteadiness. And often these symptoms actually develop because there's inflammation in the brain from the tumor causing edema or swelling. So here is an image on this left side showing the edema in red, or the inflammation surrounding the tumor. And it's this edema or swelling that's causing distortion of the brain, and that's typically what causes the patient to have symptoms. So now looking at the MRI images of patient 1, you have two different images for patient 1. You have a T2 flare and a T1 with contrast. You can see here looking at the image with the contrast, you actually can't really see the tumor, but you can see that there is some distortion in the back of this arrow. When you look at the T2 representation, you can actually see that there's a lot of swelling there, and that's what all this white is, or edema. And so that kind of hints to us that there's actually a mass there. Now, if you look at patient 2, looking at the contrast scan, you can actually see that the mass is picking up the contrast, and you can actually see what's causing the distortion. And you can see here in the flare that the edema is much more prominent. Well, the patient number 2 is a very typical representation of a higher grade glioma, whereas patient 1 is a typical representation of a lower grade glioma. The initial treatment of symptoms often consists of giving a patient steroids or Decadron, and that's basically just to reduce the inflammation surrounding the mass and thus decrease the symptoms the patient is experiencing. We also like to give anti-seizure medications, particularly if a patient has had a seizure or we feel like they might be prone to one. So Keppra or Dilantin are commonly used. What are some causes of brain tumors? Well, we do know that there are some clear causes. Prior radiation therapy to the brain. For example, if a patient had radiation to the brain as a child, it's possible that as an adult they can develop a second, different type of tumor in the brain. Genetic syndromes such as neurofibromatosis, von Hippel-Lindau, tuberous sclerosis, or Li-Fraumeni also lead to brain tumors. Possible causes include weakened immunity or hormonal. And then there are unclear causes which you often read about: hair dye, power lines, cell phones, polyvinyl chloride. None of them have actually been proven to cause brain tumors. And then, of course, there are many unknown causes. The most common brain tumor is actually metastases, but the most common primary malignant brain tumor in adults is glioblastoma. And here you can see a graphical representation of primary brain tumor where 40% is represented by the gliomas as a whole, followed by meningiomas, which tends to be more benign, and those are 30%. Just looking at gliomas, you can see that 50% of gliomas are actually glioblastoma. Adult gliomas consist of approximately 80% being high grade and 20% being low grade. How do we diagnose brain tumors? Well, as I showed you, MRI with and without contrast is key. And then surgery, whether it be a biopsy, a subtotal or incomplete resection, a near total resection, or a complete gross total resection are all helpful for us to get pathology so that we can look under the microscope and determine what exactly this tumor is. And then how do we treat? Let's say the patient has an astrocytoma. Well, we would want maximal safe surgery. And that's often followed by chemotherapy, such as Timidar, perhaps other agents such as Avastin, usually given at the same time with radiation, or sometimes in sequence. One's given first, followed by the other. I'm often asked, well, why do we need radiation? Radiation actually damages the tumor DNA, and it can do this directly, as you see here on the bottom with the arrow hitting the DNA of the tumor, or it can do it indirectly by hitting a water molecule, thus causing a free radical or an oxidant that then goes in and damages the DNA. And this is actually why I tell my patients not to take antioxidants during the radiation treatments, because then you'd be countering the effect of the oxidant killing the tumor DNA. Well, then how come the normal brain cells survive? That's the reason why we fractionate the radiation dose. This means we give daily small doses for a total large dose. And this actually allows the DNA of normal tissues time to repair while the cancer cells die off. Giving one large dose of radiation, also known as radiosurgery, can be given only when you have a very small target and will add minimal to no margin so as to spare the normal brain. And I'll go over what I mean by margin in a couple of slides. What are some radiotherapy options? There's 3D conformal therapy, there's IMRT, also known as intensity modulated radiation therapy, and that can be delivered using multiple field IMRT, rapid arc, or tomotherapy. There are protons, which are a hot topic right now, and then radiosurgery, where you can use various different machines to deliver radiosurgery, such as Gamma Knife, the linear accelerator-based or LINAC-based radiosurgery, and CyberKnife. For radiation planning for patients with brain tumors, we like to get an MRI, and then we do a CT simulation. And this is just a CT, not for diagnosis, but we use the CT for our planning. And actually, at that time, it allows us to make this plastic mask that goes over the patient's face, and it holds the head in place during the daily treatments. So it's an immobilization device. Then what we like to do is we like to fuse the CT to the MRI. And here on the left, you can see that this is a CT part of the image. This is the CT part of the image. And it's fused with the MRI, and we're checking here to make sure it's precise. Then the physician actually contours on the MRI both the tumor and the normal structure, and that transfers over the CT, and then the physicist uses that CT to do the planning. And here's what an actual fusion looks like. You're looking at a CT and an MRI over one another, and that small box that you see going over it is basically just checking to make sure that the fusion is precise. So here you can see the A on the left here is an MRI, and the pink shows that that's where the tumor is, and it's drawn here. And on B, it's the CT scan, and that's where the radiation doses are presented on the CT. So the drawing transferred from the MRI to the CT, and then the CT was used to do the plan. So as I mentioned, the physician contours normal structures in the brain as well as the brain tumor, and that's known as the gross total volume, or GTV. Then we add that appropriate margin to the tumor for any microscopic disease that's not seen. That's also known as CTV, or clinical target volume. So an example I like to give my patients is imagine an octopus. So the head of that octopus is your GTV, or the brain tumor. And the tentacles are the CTV, because those you don't really see, but they're underlying in the normal brain. And so you want to make sure that you give a margin to cover that area. Then you also add a very small margin, a couple of millimeters, just for possible motion or setup changes. And that's the PTV, or planning target volume. And you do that even though you have that face mask. You want to be sure you're within a millimeter or two accuracy, and so that's what this helps. The physics team then plans according to the physician's specifications, and then the physician has to approve, perhaps even fine-tune the plan before it is ready. So what we look at is dose to the tumor versus dose constraints for the normal tissues. So what do these normal tissues accept and tolerate? And we look at various structures such as the eyes, ears, nerves, and normal brain. So here's looking at a final plan on a patient. The top part looks at the distribution in various different images of the actual dose of the radiation. So the red is where your actual main target is, the planning target volume, and that's where you deliver the highest dose. The yellow, green, and blue are lower doses that just scatter or fall off. But then ultimately what we do is we look at a dose volume histogram, or a graphical representation of all the normal structures and the dose that they're getting, as well as the dose that the tumor is getting. And we want to make sure that all the normal structures meet the safety criteria. So as I mentioned earlier, there are multiple different ways of delivering IMRT. You can do 7-field IMRT, which has beams coming from different angles like this, and each one can be weighted differently. And what I mean by that is, for example, this beam here can be just a couple of % of the whole plan, whereas this beam here can be a majority, maybe 50% of the plan. You can also do arc therapy, and that means you can go around the tumor in an arc distribution. You could either do a complete arc, all the way around the patient or the tumor, or you could do a half an arc in one direction and then a half an arc in the other direction. And then tomotherapy is a newer way of doing this, where the radiation actually goes 360 degrees around the tumor, the target, and delivers dose in that manner. Again, here's an example of comparing various plans. In this left side, you have 3D IMRT and then rapid arc IMRT. And what we look at as physicians is we look and see how well the dose that we want hugs the tumor and how little the normal part of the brain gets any scattered dose. And so we do a comparison. And looking here at the right, we're comparing IMRT in 3D. The blue line is actually the 100% dose. So that's the exact dose we want the tumor to get. And you can see on the left, the IMRT hugs it more tightly than the 3D conformal plan. And then you can see the orange, which is the 50%, and the yellow, which is the 12% line. Those are much lower in the IMRT plan than the 3D conformal plan. So we like to do this for our patients just to make sure we select the best possible plan. Now, one thing I'd like to say is it's often thought that because 3D conformal is an older technique that it's not going to be the best one, and that's not always the case. Based on the location of the tumor, sometimes 3D conformal plans will give you a better plan than an IMRT. So we do like to try all our options. Here's looking at another plan, tomotherapy versus arc therapy. And when you look here at the dose volume histogram, the blue line represents tomotherapy, the dashed line represents one type of arc therapy, and the dotted line represents another type of arc therapy. And you can see that the dotted line gives the lowest dose to the brainstem and the optic nerve, and gives the best dose to the PTV, your volume, your tumor volume, and so that's the one that would be picked in this situation. I'm also often asked, well, how can you shape according to the size and shape of my tumor? Well, this is what we use. These are called multi-leaf collimators, and they're in the head of the gantry. They're in the head of the radiation machine while it's delivering the radiation. And literally, these fingers move in and out, and they conform or shape to the shape of the individual patient's tumor, and that's how the dose is able to be delivered precisely, while sparing the normal structures in the brain. And you can see that the fingers are moving in and out as the machine rotates around the patient. There's various different machines. Here's an example of two that we have. Novalis, which delivers IMRT, rapid arc, and radiosurgery, and then tomotherapy. And here's an example of a treatment delivery. That red flash is the lining up of the patient. It's infrared. And then now the machine rotates around the patient and takes various x-rays. And these x-rays are matched to the day that the CT was done for planning. We have to make sure that those line up properly before we proceed. Once we're happy with the various images, then the treatment can start. And you can see here how the treatment's very focused in on the tumor region, and it delivers the dose. Each time the beam changes angles, new images have to be taken, and they have to be approved, make sure that they match perfectly, and then additional dose can be delivered. And you can see that the machine moves, but also the table that the patient is on can also move, so that we deliver the best conformal or most shape-hugging plan. Protons. I'll just briefly touch upon them because they're so popular right now, especially when you Google it on the internet. It's useful for some pediatric tumors, but it's also useful for some brain tumors in adults, such as chordomas, which require a very high dose, and they're often next to critical structures such as the optic nerve. Now, the beauty of protons is that you could see here, they have a very low entry dose, and then they peak high where you want to deliver the dose at your tumor, and then they sharply fall off so they don't have much of an exit dose, so they don't scatter dose to nearby structures. And that's the beauty of having to treat something next to a critical structure and using protons. However, we do actually need a lot more data to make sure that they're as efficacious as photons in treating various tumors, including brain tumors. So what does a patient's team consist of? It's the physician. At an academic university, it would consist of an attending physician and a resident physician. And then there's often a nurse practitioner and or nurse. Then there's radiation therapists who work with the patients, setting them up on the table each day. The physicists and dosimetrists who do all the behind the work planning for the patient, behind the scenes planning for the patient. Treatment days. Typically for brain tumors, it's 28 to 33 consecutive days, depending on the diagnosis. We don't treat on weekends or holidays, so this May-June calendar is an example of where in red the weekends are marked off, and on the 27th it was Memorial Day, so that was a closed day. Prior to treatment, the physics team actually does several quality assurance checks to make sure that the plan is matching precisely from the computer to the machine. And on the first day of treatment, the physician actually comes in the room and checks the setup with the radiation therapist team in the treatment room. So what we're looking here is to make sure that the lasers line up properly on the patient. We also check daily the images to make sure that they match the day of the CT. So on the left is one way of doing that, where you can overlay in this box your daily image and you match it to the CT image done on the day of planning, or you can look at it like this with the grid side to side. Essentially, you want 1 to 2 millimeters of accuracy. Physicians will see you at least once a week at a set time to review any problems, questions, or concerns, but there's physicians and nurses available daily if it's needed. What are some side effects to expect during treatment, or acute side effects? Hair loss, and this is typically only in the radiation field, but it will depend on if you use an arc versus a beam distribution. So if you use just a beam distribution, it might just be a patch of hair that's lost. If you use an arc, it could be a halo around the head that's lost. It typically regrows 3 to 6 months later, though in some cases it may not regrow or only partially regrows. Skin irritation can occur, just a little bit of redness or dryness in that area, but it's usually treatable with just some moisturizer with no fragrance. Fatigue can develop, especially by week 3, and progressively increases, and this resolves approximately 2 weeks after radiation therapy ends. Then there are symptoms related to inflammation from radiation, and this can cause its own swelling and edema. This can mean temporary development of symptoms such as nausea, vomiting, or headache, and perhaps temporary worsening of any symptoms the patient already has. So this may require steroids for treatment or an increase in dose of the steroids, and it might require an increase in anti-seizure medications if a patient has a breakthrough seizure during the treatment. Late side effects to think about after completion of radiation. One is radiation necrosis, and this is just a fancy term to mean dead cells caused by the radiation. So the radiation worked, killed those cancer cells, and now they're kind of sitting there until the body clears them out. Sometimes this can cause its own swelling or edema, and they may require steroids for treatment and rarely surgery for treatment. Other side effects will depend on the location of the tumor and the radiation field, and these can include hearing loss, endocrine abnormalities, cataract development, worsening of short-term memory, and possibly cognitive decline, and this usually presents as decreased new learning ability and problem-solving skills. Though I always reassure my patients that they remain fully functional and can continue working. So just to summarize, a patient's team for a brain tumor consists often of a neurosurgeon, a neuro-oncologist who's the chemotherapy specialist, and a radiation oncologist. And the goal of treatment is for cure, prolonging life, increasing the quality of life, and minimizing side effects. Thank you, and you can ask any questions on Twitter using hashtag UCLAMDChat. So the first question is there side effects with radiation therapy? I presume that was written probably before I got to my last couple of slides. If you have more questions, feel free to Twitter them in on specifically any side effects. Are there any type of brain tumors that are best treated with radiation? That's a good question. We actually often like to use all 3 methods, surgery, chemotherapy, and radiation for the treatment of most tumors, but not necessarily. There are some benign meningiomas where if they're small enough and they're not causing a patient's symptoms, we'd like to just go ahead with radiation over surgery so we don't put a patient through a very invasive procedure. So it does vary, but these are the 3 modalities that are often discussed, and we pick the best one or a combination of the 3. What are some of the risk factors of brain tumors? As I mentioned, having prior radiation therapy to the brain is one, and then having various genetic syndromes. Most of the other ones are all unproven. Can brain tumors be prevented? Unfortunately not. If you've had prior brain radiation therapy, it means that it was necessary at that time. So with our modern technology, we try to spare dose to normal parts of the brain, so that might help. But otherwise, there's really no way of preventing a brain tumor. That was asked twice. What is the best treatment for brain tumors? Again, it varies depending on the diagnosis, the location, the symptoms that the patient's having. If they're having a lot of symptoms and it's because of mass, surgery is a good way to go, but they might need chemotherapy or radiation later. What are the side effects of radiation therapy for meningioma brain tumors? It depends on the location and the size, but if it's small enough and you just did radiation therapy, often patients have no symptoms or very minimal. Maybe a mild headache during treatment that's relieved with Tylenol, and then really in the future, nothing. So it again varies. If they presented with a lot of symptoms, we would actually like the neurosurgeon to remove it first, and then we would consider if radiation was appropriate. What can I expect after radiation treatment for my brain tumor? So in addition to, I imagine this might not just be referring to side effects, we would follow you as a team closely with serial MRIs or routine MRIs to make sure that the tumor is staying quiet, shrinking, and not growing. And then we would determine your treatment accordingly. How is a pediatric brain tumor treated? Pretty much the same way. If it's something where we feel like a patient needs protons, we would refer them for that, but that's usually in cases where we feel like normal parts of the brain will get dose that cannot be spared with photons. But we really just treat them in a similar fashion as what I just described. Thank you very much for joining us today. Please feel free to ask any questions now and in the future.